I would like to welcome Dr. Kathy Warren. She's the head of the Pediatric Neuro-Oncology section of the Pediatric Oncology branch in the National Cancer Institute. She received her MD from Tufts University and performed a pediatric residency at Children's Medical Center in Washington, D.C. This was followed by a clinical fellowship in pediatric hematology oncology at the National Cancer Institute and a research fellowship in the Pharmacology and Experimental Therapeutic section of the NCI. She's a principal investigator on several institutional and national investigational trials. She participates in the Pediatric Brain Tumor Consortium, where she is a member of both the steering and scientific committees, and holds position of chair of the High-Grade Glioma Committee and co-chair of the New Agents and Therapeutics Committee. Her work is focused on tackling obstacles to chemotherapeutic treatment of CNS tumors and non-invasive assessment of therapeutic response. She's also one of my favorite.
Thank you, Al. That's what we sort of need something in between, but we'll adjust as needed, I think, on the slides. That's okay. But I want to thank Al and the organizers for inviting me to speak today. It's an honor and a privilege for me to be here, and it's actually this kind of interaction that renews my passion for what I do, and sometimes we need renewal. The focus, major focus of my research is developing new agents for children with brain tumors, but not only looking at new agents, but trying to also look at why some agents don't work and strategizing ways to get around that. It's a very exciting time in drug development right now. It seems like almost monthly there are new targets being identified or new drugs that are making it into clinic, but how best to incorporate those into clinical trials, particularly for pediatric patients, remains to be determined. So today I want to discuss, I'll start off with an overview of pediatric gliomas and go over my treatment approaches, including the role of chemotherapy. And we will, on the way, talk about the development of new agents and some of the issues that come up for us when we're doing this. Al also asked me to mention some of the things that are going on at the National Cancer Institute in Bethesda in our intramural program. So let me start with the numbers. The National Institute of Health defines a rare disease as one that has a prevalence of less than 200,000 patients a year in the United States. This is a pie chart showing all the brain tumors diagnosed in the United States between 2004 and 2007, so over a 3 to 4 year period, and this is the totals. So this classifies as a rare disease. The majority of the brain tumors are non-malignant brain tumors in adults, and it's represented by this red part of the pie. Second is the malignant brain tumors in adults, represented by the blue. This very small piece of the pie here is what's represented, is representative of the pediatric patients, with the green being the malignant brain tumors and the, whatever this color is, being the non-malignant brain tumors. Now we can take that small piece of the pie and break it down even further. Pediatric brain tumors are actually a very heterogeneous group of diseases. By that I mean it's not one diagnosis. There's different biology, there's different histology. And so you take that thousands of patients that were in the prior piece of the pie, and now we're talking about hundreds diagnosed each year with each of these diagnoses. And you can probably surmise that this is not a very lucrative population for pharmaceutical companies to get involved with. If you look at the overall 5-year survival for children with tumors of the central nervous system, so this includes brain and spine, from 1975 through 2002, you can see that over 70% of children will survive at least 5 years with brain tumors. We know that sometimes that's survival at a price because children sometimes have effects from their tumors or their treatment. But the overall survival, and this is broken down by age groups, with the blue being 0 to 4 years, yellow being 5 to 14, and gray being 15 to 19. Overall survival in the last 35 years or so has improved, although not as much as we would like. It's important to note, though, that this is the overall survival, and if you break this down by diagnosis, things look a little bit different. So for juvenile polycytic astrocytomas, medulloblastomas, and low-grade gliomas, the overall survival for 5 years is very good, as opposed to children with high-grade gliomas and diffuse intrinsic pontine gliomas, whose overall survival remains poor. So how do we go about treating, our approach to treating these patients? We take the chances of overall survival into consideration when we're deciding how to treat them. The three things that we have in our armamentarium at this point are surgery, radiation, and chemotherapy. Surgery is done initially to establish a histologic diagnosis in most cases. We want to reduce the tumor bulk, and Mike talked about some of this, primarily to improve symptoms, surgery can be a cure for some low-grade tumors, and it can, if you do an extensive resection, it can improve survival of children with high-grade gliomas. Radiation is usually given at some point in time for children with malignant tumors, but we try to defer it as best we can, particularly in younger children and children who have neurofibromatosis type 1, who are particularly susceptible to the effects of radiation. And I'll talk about the role of chemotherapy for the different tumor types, but our guiding principle when we talk about treating all of these patients is risk versus benefit. So if you can take a tumor out completely and easily in a patient who has a low-grade glioma, go for it. If it will cause significant neurological damage, then you may not be as aggressive as you would be for a patient who has a higher grade tumor. One of the things we take into consideration when we're talking about the apparent risk-benefit ratio is the grading of the tumor. So when you take a tumor out, part of it goes to the pathology lab and they look under a microscope at the grading of the tumor. And it's graded on a scale of 1 to 4, basically based on how much it looks like a normal cell or how dissimilar it looks to a normal cell. So grade 1 tumors are the, quote, least malignant. They appear similar to normal appearing cells in the brain. They're usually slow growing and they're well demarcated, so they have a very distinct border. Grade 2 tumors are a little bit more abnormal. They don't quite look like normal cells. They are relatively slow growing, but they can spread into the surrounding nearby tissues. Their borders are not as well demarcated. And in adults in particular, low-grade tumors can come back as a higher grade. We don't really see this in pediatrics, and it's really not clear why. Grade 3 tumors are malignant. Malignant means bad. They're actively dividing, and they invade normal tissue. And grade 4 is very abnormal under the microscope, and by definition, they either have new blood vessel formation or areas of necrosis or both. So the difference between grade 1 and 4 is very clear. The differences between 2 and 3 is kind of a call for the pathologist. In general, we call grade 1 and 2 tumors low grade, and grade 3 and 4 high grade, and sometimes you'll see grade 2/3, and you really don't know what category that falls into. So this is an MRI scan of a patient who has a Polycytic astrocytoma. This falls into the grade 1 category. This is an MRI scan from a patient who has a glioblastoma multiforme, the grade 4 category, and the white that you see is what the tumor looks like after contrast enhancement. Now again, the lower grade tumors, you can almost outline the extent of the tumor, whereas in the high grade tumors, you can't. We know that there are some tumor cells out here, and this is basically shades of gray that we're looking at, but you can't see all of the tumor cells that are present on the higher grade tumors. And this is what they look like under the microscope. So the dark blue that you see are the nuclei of cells. So each, if you see a lot more blue, there's a lot more cells. On the higher grade tumor, this red is new blood vessel formation. You can actually see some cells that are in the process of dividing. There are some tumors like pontine glioma where we never get tissue. Biopsy is considered not the standard of care for these children because they have most of them have a typical presentation and typical features on the MRI scan. They have this very large expansive mass that looks darker on this T1 weighted image. They have a very bright appearing mass on this T2 weighted image. The tumor is centered right here in the pons part of the brainstem. And so when we see this in the face of what we call a typical presentation, a biopsy supposedly is not needed. But as a result, there's very little tissue available to study this tumor. So I'm going to talk about my current approach to these tumors. This may vary. Some of it's controversial. But this is basically how I approach these patients. So for children who have low-grade gliomas, as I mentioned, if you can take it out easily, take it out. If you can't take it out completely, or if you can't take it out at all, then radiation and chemotherapy are options, but we try to defer radiation if at all possible. It used to be we would defer it in children under age 3, and then it was children under age 5, and now we try to defer it for almost everybody because we know that the effects of radiation can affect all children. But there are some cases where we would consider radiation up front, and those are, in my opinion, if the tumor is progressing very rapidly or if there's impending vision loss. Chemotherapy, I treat patients with supposed low-grade gliomas with chemotherapy if there's evidence that the tumor is growing or if the patients are symptomatic. Sometimes you see low-grade gliomas that are picked up incidentally. They're not causing any symptoms. You don't know how long they've been there, and we choose to just watch them over time to see what happens. Then if they show evidence of growth, we go ahead and treat. Chemotherapy plays a very important role in the management of children with low-grade gliomas. There are two frontline chemotherapy regimens which are considered very active. The first is vincristine and carboplatin, and the other is this combination of 5 drugs, which I won't even tell you. But basically, both of these can cause an objective response rate. That's that ORR, which means they decrease the size of the tumor. But both of them also can prolong the time to progression. So the vincristine carboplatin, for most newly diagnosed patients, they can continue on this regimen. They have 3-year progression-free survival of 68% or so. And these two regimens are fairly similar in their outcome. But about 50% of children who have a low-grade glioma will at some point need additional chemotherapy. So this chemotherapy doesn't work forever in about half of these patients. Luckily, though, we have some other therapies that are considered active in this disease, and this includes weekly vinblastine, oral etoposide, and temozolomide. So we know we will be treating these patients for long periods of time, and our goal is to treat them with the least toxic therapy available because we want them to be able to tolerate the medicine for a long time. So for example, if a medication causes chronic constipation or diarrhea in a 13-year-old boy with a low-grade glioma, he's not going to tolerate it. Whereas if there's some activity in patients with high-grade gliomas, you may say it's worth the risk of doing that. Now, the role of chemotherapy for pediatric high-grade gliomas is more questionable. The initial study, this one right here, was done in the 1980s, and they compared radiation, that's XRT, with or without chemotherapy, and this is prednisone, CCNU, and vincristine. And their results were great. They had 40% 5-year progression-free survival with chemotherapy. The problem is this was a small study. I think there are between 50 and 60 patients enrolled on this, and nobody can duplicate those results. The next study compared this PCV regimen with this 8-in-1 chemotherapy, which gives 8 chemotherapeutic drugs in one cycle. And the 8-in-1 chemotherapy had a 33% 5-year survival compared to 28% for the PCV. So what was going on here? We went back and looked at the histology of these tumors, and we found out that a large percentage of them were actually low-grade gliomas. And so subsequent trials actually required much more stringent definitions of high-grade gliomas and did central review of the pathology. So several pathologists were looking at it and making a decision on the grading of the tumor. And so it may look like the 5-year survival is actually decreasing over time, but that's basically because of this more stringent criteria for study entry. The most recent trial that was published in the past year is this radiation with temozolomide. Now, radiation and temozolomide is essentially standard treatment in adults with high-grade gliomas because there's 2-year overall survival of about 25%. There is some activity in the adults. However, unfortunately, in children, we didn't see that. The results were fairly disappointing, with only 11% of patients going 3 years without progression. And so now there's no standard of care for these children. We know that we resect as much as you can. We know that we give radiation, but beyond that, there's really no standard of care at this point. Now, the role of chemotherapy for diffuse intrinsic pontine gliomas, there is no role. There has never been a study of chemotherapy done in a scientific setting in a large group of patients that have shown a significant improvement in outcome of children with pontine glioma who got chemotherapy. In fact, these are the survival curves from the 2 most recent studies. Again, this is the one with temozolomide. And basically, these curves look the same no matter what regimen we give to these children. There's a rapid drop-off. There's about median survival is 8 to 11 months, and that's exactly the same as it was in 1979. So what's going on here? We have gliomas, some that are responsive to chemotherapy. We have some chemotherapy regimens that are active in adults but not in children. So we just want to take a step back and say, okay, what do we need for a drug to work? First of all, we need an active drug, of course. We need it to be delivered to the tumor site. It has to be present at the tumor site in its active form and in effective concentration. So if there's not enough of the drug to work, it's not going to work at all. It has to be there for a long enough period of time to be effective. The cells have to be sensitive, and it has to be tolerable at the doses that are necessary to achieve all of the above. So there are several factors that can affect drug levels at the brain tumor site. One is the concentration of drug in the bloodstream. Some drugs bind significantly to protein and tissue, and it's the free or the unbound drug that's actually active. So if you take an example of carboplatin, 97% of carboplatin is bound to protein and is not considered available or active at the brain tumor site, and only about 3% gets across the blood-brain barrier. This blood-brain barrier I'll talk about in a moment, but it basically, as Mike mentioned, developed to protect the central nervous system from environmental toxins. The rate of blood flow to the tumor is one factor that affects the drug levels at the brain tumor site, and diffusion of the drug across the brain parenchyma, or the brain tissue, is also important. So once the drug crosses the blood-brain barrier into the brain, it then has to travel across brain tissue to get to the tumor. So this basically underlies the importance of doing pharmacokinetic studies, and this is not really taken into consideration by pharmaceutical companies. We'll talk about that a little bit more later as well. So this is a schematic trying to demonstrate the blood-brain barrier. This was done by Dr. Frank Bayliss, who was my mentor. And it compares the capillaries in the body outside of the central nervous system on this side, and this side compares the capillary in the central nervous system. So in the body, you have this single layer of what we call endothelial cells that make up the lumen, or the sides of the capillary, and the blood flows through the middle. These normal endothelial cells are divided by these fenestrations, or opening, which allow substances that are within the lumen of the capillary to escape into the tissue. Some substances can also cross the endothelial cells directly by this process called penocytosis. However, in the central nervous system, the capillaries are sealed. They are sealed by these tight junctions, so you don't have these fenestrations to allow anything to cross over. You also have something called this efflux pump, which is present right on the inside border of the cell, so any drug that tries to cross over will be pumped right back into the center of the lumen. If a drug is lucky enough to cross the blood-brain barrier, it then encounters these supportive cells that are in the central nervous system. And so normally when a drug crosses, it has to keep crossing over this tissue to get to the tumor, and these are additional barriers. If you look at the blood vessels that are formed in tumors, they're not normal. So you don't see any of these round normal capillaries here. These are all broken capillaries, and this is a picture, an electron micrograph of some capillaries. You can see they're tortuous, they're different sizes, they're twisted, they're also leaky. Okay, so if you're trying to get blood to flow through here normally to get to the tumor, blood flow is not normal. There's also some breakdown of these capillaries, and so people say there is this blood-tumor barrier, and if contrast like gadolinium can get across, well, drugs can get across. The problem is, and again, Mike alluded to this as well, even if a drug gets across, it doesn't go very far. So basically, this is a graph looking at how far away the drug travels when you give it directly into a rat brain. And you can see we're measuring millimeters. So the farther you get away, when you get to 2, 3, 4 millimeters, you get very little of the drug. If you need this kind of concentration for the drug to be active, it's only going to be active in a very small area. And this is true also for these BCNU wafers. We know that over time and over distance, the concentration drops off dramatically. So how do we get around this? So we have tried high-dose chemotherapy. You basically increase the amount of drug that you put into the veins. This is toxic to the patients for most agents, and in most cases, there's no improvement in survival either. We can identify drugs which penetrate the blood-brain barrier. Temozolomide penetrates the blood-brain barrier very well. Over 75% of the drug gets in. We know that there's adequate levels in the central nervous system, but still it doesn't work. There are other mechanisms that we have to deal with. We can disrupt the blood-brain barrier. People in Oregon in particular do this osmotic disruption. We have tried lobratomil, which relaxes those tight junctions and temporarily improves the delivery of agents into the central nervous system. However, we did not see any effects, any responses in high-grade gliomas or diffuse intrinsic pontine gliomas. You can also try to block the drug efflux pump. That P-glycoprotein inhibitors basically can block what is trying to cross the central nervous system. When we tried this for kids with diffuse intrinsic pontine glioma, the study had to be stopped early because of toxicity. So these inhibitors, these pumps are there for a reason. And so we move on to regional chemotherapy, where you give the drug directly near the tumor. I work with Ed Oldfield and Russ Lonser, who are the people who essentially developed this technique called convection-enhanced delivery. If you put a drug into the central nervous system and just leave it there, it will spread by this process of diffusion. It goes from a high concentration to areas of low concentration, but it does that kind of unevenly and it doesn't go very far. If you push the drug under slow and low pressure, that's called convection, it spreads farther and more evenly. So we now have a trial, a phase 1 study where we're instilling this IL-13 Pseudomonas exotoxin in children who have progressive pontine gliomas and supratentorial high-grade gliomas. It's phase 1, and our objectives are feasibility. Can this be done? Can it be done safely? Do the children tolerate it? And then we look to see if it works. So this particular study is done only at the NCI.
Is this currently open?
Yep, it's currently open. It's done only at the NCI. We're looking at patients with pontine glioma in one arm and patients with high-grade glioma in the other, because we think that there's 2 different sets of risks here. Patients with pontine glioma basically have increased pressure in their brainstem. Patients with high-grade gliomas can have their tumor resected, and you basically have a hole and lots of room with less pressure in order to instill the drug. We basically define the area of the tumor using what I call multiparametric imaging studies, which are fancy MRI scans which take 3 hours to perform. And we're dose escalating what we're administering. So this is the schematic of the IL-13 toxin. Cancer cells, particularly high-grade gliomas, have this IL-13 receptor on them. This has been identified in 70 to 80% of high-grade gliomas in adults. It's not found on normal cells, mostly. And it's been found in about 60% of children who have diffuse intrinsic pontine glioma. So this toxin recognizes this IL-13 receptor, it's internalized, and then it kills the cells directly. So it doesn't have an effect on the normal cells because they don't have the receptors. So we've done this. We've done this procedure in 3 children with pontine glioma. Up top is a cartoon. It's a coronal section, so we're looking like this, and the ears would be at the side. So we identify the tumor site, and the neurosurgeons decide where and how they're going to place the catheter. They try to avoid the ventricles, which are here, and they try to avoid the most elegant parts of the brain as best they can. So you can see there's a very narrow window here for the trajectory of the catheter. But we did this in, this is images from a 3-year-old girl who got this. We defined the tumor as this area right here. We administered the IL-13 along with the gadolinium so we could see where it's going. This procedure is done in the operating room. We're limited to 10 hours of infusion. That's a long time in the operating room, so we want to see how much can we give in that 10-hour period. And on this patient, you can see over time, we have an MRI scanner in the operating room suite, and they're imaged in real time. You can see that the area of the tumor basically was covered with this IL-13 Pseudomonas exotoxin. So everybody wants to know, does this work? It's feasible, it's safe. This patient was back to her baseline within 2 days. Unfortunately, her tumor did not shrink and actually progressed over 3 months. We had another patient, a 16-year-old, who we were only able to infuse half of his tumor. The half that we infused did not grow, and the other half did. And so there's some hints that maybe it was active in his case. Now we know that IL-13 receptor is not present in all tumors. This is basically a slide showing normal cells. You can see there's no IL-13, and the IL-13 is going to be in green. This patient had high expression of the IL-13 receptor. This patient had it on some cells but not others, and this patient did not have it. And so for our study, we could not do a biopsy first to see if this patient had IL-13 receptor, number 1, because biopsy is not standard of care, and number 2, the biopsy can cause some bleeding within the tumor, and you have to give it time to heal. So you can't just watch a patient with a pontine glioma for 2, 3, 4 weeks while this area heals, because their tumor will continue to progress and they may no longer be eligible for the study. So when we look at traditional drug development, we don't really look for these targets specifically on our patients. The traditional drug development is primarily based on cytotoxic agents, which is what we had initially when we gave chemotherapy to patients. Cytotoxic agents are agents that kill the cells directly. They primarily attack dividing cells. So we would do some preclinical testing where you look at the mechanism of action of an agent. You see if there's any activity in the test tube or in some animal models. If so, it moves to phase 1 testing where we look to see, number 1, is it safe to give? How well do the patients tolerate it? what's the maximum tolerated dose, or how much can you give to a patient? We have this mindset that more is better for cytotoxic agents. And we look at the pharmacokinetics, or basically how does the body deal with this drug. Once we define this maximum tolerated dose, this is the dose that goes on to phase 2, where you actually look at the drug against a specific set of tumors to estimate any activity. If there is activity, then it moves to phase 3. Now, in the past and currently, this paradigm for drug development occurs in children first. I'm sorry, in adults first. When it gets to the phase 2, if there's some inkling of activity, then we go back and say, okay, let's test this in children. If there's no evidence of activity, pharmaceutical companies have been a little bit hesitant to pursue it in pediatric patients, and so some drugs that may be active in pediatric patients never make it that far. You say, well, why do this in children at all? Why not just give them the adult dose? Well, when we're looking at drugs, pharmacokinetics is very important. So it's not, we call, if you increase the dose of a drug and you get increased levels in the body in proportion, that's called linear pharmacokinetics. There are some drugs, though, where you give a little bit of the drug, you see this huge effect immediately, and if you keep giving additional doses, you get no additional effect. We have some other drugs where you give drug, you increase it by 10 times, you don't really see much of an effect until you give huge doses of the drug. And so it's important to know how a drug behaves in the body. We also have something called the therapeutic window. We're not just looking at the therapeutic effect, but we're looking at the toxicity. So there are some agents where you can give lots of the drug without getting any toxicity, and you would have to give huge doses of the drug in order to see side effects. There are some other drugs, though, and this is most of the cytotoxic agents where the toxicity overlaps with the therapeutic window. So if you're trying to reach this level for an effect, you can see that it overlaps with the toxicity, and even small increases in the dose will cause more toxicity. So people have done studies looking at the adult maximum tolerated dose defined in phase 1 studies and compared them to pediatrics. And you can see there's a fairly good correlation. These open circles are biologic agents, the black circles are cytotoxic agents. There was another study, though, that showed 16 out of 17 cytotoxic agents were better tolerated in children than they were in adults. We have had experience with at least 2 drugs where we've had better tolerability in the pediatric population than they do in adults. So this agent, lenalidomide, also known as Revlimid, is FDA approved for adults with multiple myeloma and myelodysplastic syndrome, and it's under clinical investigation for a number of other illnesses. It's classified as an immunomodulatory agent because it affects the immune system. It changes the production of some growth factors. It stimulates certain T cells or lymphocytes in the body, which help fight off intruders. It also has a direct anti-tumor effect, so it induces apoptosis, which is programmed cell death. It also has effect on the tumor microenvironment in that it inhibits new blood vessel formation. So in the adult trials, they did the phase 1 study, and when they got to doses over 50 milligrams per meter squared, they saw a lot of myelosuppression. So there was decrease in red blood cell counts, decrease in white blood cell counts, decrease in platelets, and this was dose limiting, so they couldn't continue to increase the dose because of this toxicity. The rest of the pharmacokinetics were appealing for the agent. The adults tested this drug in their brain tumor trial, and they said, okay, we know over 50 milligrams per meter squared causes myelosuppression. The highest we'll go is 40. And they enrolled a number of patients. They did not see any responses. I think they saw one patient who had long-term stable disease, but overall the results were fairly disappointing. Now, when I mentioned that the drug is FDA approved for multiple myeloma and myelodysplastic syndrome, it's approved at these doses, 25 milligrams or 10 milligrams a day given for 21 days. So we tested this in children. We started off with our objective was to estimate the maximum tolerated dose in children. Is it the same as adults? Is it lower? And we generally start off in pediatrics at a dose that's about 80% of the adult tolerated dose. And you enroll 3 patients on this phase 1 trial, and there was no dose-limiting toxicity. We went up a little bit. We were a little bit hesitant at this point. We enrolled 4 patients. One patient had what appeared to be a heart attack, but she had 5 other risk factors for heart disease, and so it was unlikely related to the drug, so we crossed our fingers and we kept going. And we kept going, and we kept going, and we continued to increase all the way to 116 milligrams per meter squared, and we still did not have our dose-limiting toxicity that would stop the trial. The patients were tolerating it very well. We also wanted we took a look at the toxicities. The side effects that we saw were very similar to what the adults had, but ours were lower grade, and the patients were able to tolerate it much better. What's important, we looked at the pharmacokinetics to see if there was a difference in the way that children handled the drug compared to the adults. And this looks at the dose level, your increase in the dose, and this is the exposure, so how much your body sees of the drug over time. And this is what we call linear pharmacokinetics, where you increase the dose, then you increase the exposure. We saw the same effect in the children. Now, if you look, we studied the higher doses in the children. This red box right here represents all of this adult. You can see that we were able to get 10 times the exposure in the pediatric patients than they did in the adults. And that's important when we talk about response. So we had 44 children who were evaluable for response. We saw 2 objective responses, which means the tumor actually got smaller. One patient had a polycytic astrocytoma who had a partial response, which decreased by 50% or more after cycle 9. She was treated at a high dose level. One patient had an optic pathway glioma who had his tumor shrink by more than 50% after cycle 1, and he was treated at a very high dose level. What was exciting, particularly for a phase 1 study, is that we had 23 patients who had stable disease for at least 6 months, 6 courses of therapy. You don't usually see this on a phase 1 study. You usually have about 10% of children who will respond to the agent, and they usually are on phase 1 studies for 1 or 2 cycles. So when we saw this, something was going on. We actually had 10 patients who stayed on for at least 12 courses for a year. We had a handful that stayed on for 2 years, which was the length of the study. But what was interesting is 16 patients stopped for toxicities rather than disease progression. They couldn't tolerate the drug for long periods of time. And remember, phase 1 studies aren't really designed to look for toxicities for long periods of time. And so our phase 1 study, we were excited about it, but there were still some remaining questions. What's the minimum exposure you need for response? We saw long-term stable disease at the lower dose levels, but we only saw the objective responses at the higher dose levels. We saw toxicities at every dose level. The toxicity didn't necessarily increase with the increasing dose level. So basically, how do we determine what the recommended phase 2 dose is? Are higher doses better or not? We don't know. And why do children tolerate it better than adults? We still don't have that answer. Right now, we have a phase 1 study combining lenalidomide with radiation for newly diagnosed patients with pontine gliomas and high-grade gliomas, which is being done only at the National Cancer Institute for a variety of reasons at this point. But basically, so we can do this multiparametric imaging and make sure what a response is or long-term stable disease is what we would agree is long-term stable disease. Now, you may say the first study was a fluke and it was just our handful of patients. Adults with high-grade gliomas did this study. They weren't able to tolerate more than 15 milligrams of lenalidomide with their radiation. We're currently at 52 milligrams per meter squared of this lenalidomide given with radiation. When children finish the radiation, they go up to 116 milligrams per meter squared, and we have 4 children who are tolerating that just well at this point. So the study is continuing to accrue patients, and right now we're at only the 2nd dose level. There's a phase 2 study of lenalidomide that's being developed within the Children's Oncology Group. We're at the point where we're in the process of writing the protocol. This takes a lot of discussion with a lot of different people, but it will likely be open for children with polycytic astrocytomas and optic pathway gliomas, and our plan is to look at a low dose and a high dose, have 2 separate arms for these patients, and see if one group of patients do any better or worse than the other. We're also, for both of these studies, we're looking at the pharmacokinetics, measuring the amount of the drug in the blood to see if this correlates with response. We have plans to combine lenalidomide with vincristine and carboplatin, which again is one of the upfront treatments for children with low-grade gliomas, because if there's activity identified in this phase 2 study, we may want to bring it into upfront treatment for children, and we don't know what that dose that they can tolerate will be. Now, cytotoxic treatment differs from targeted treatment in a number of ways. So the effect of the cytotoxic treatment is nonspecific. It affects dividing cells anywhere, and that's why you have hair loss and mouth sores. Targeted therapy only affects the cells that express the target. The effect on the cells, cytotoxic agents actually kill the cells. targeted therapy is cytostatic, which means it prevents it from growing, doesn't necessarily kill the cells. The therapeutic index, so how much of the drug can you give before you see toxicity, is low. If you give slightly higher doses of the drug, you'll see more side effects, as opposed to the targeted therapy, where our experience is you can keep giving more and more and more of the drug without seeing significant side effects. And so your question is when to stop. So this phase 1 endpoint for cytotoxic agents is usually maximum tolerated dose. Targeted therapy, it's what we're calling the recommended phase 2 dose, and this is not really defined very well at this point for clinical trials. The side effects from cytotoxic treatments are seen acutely, quickly, usually within the first couple of weeks, whereas targeted therapy, you may have some chronic toxicities exposed. Phase 2 endpoints, how do you tell if the drug is working? So for cytotoxic treatments, when they actually kill the cells, you expect to see a decrease in tumor size. This is a time to event, so we're trying to incorporate this time to event studies, so time to progression, in our cytotoxic studies as well. For targeted therapies, you don't expect the tumor to shrink, so you rely on this time to event or progression-free survival or overall survival, which means that the studies take longer to complete. But when we're looking at targeted therapies, there's some additional information that we need to know. We need to know what is the target. Is the target present? Is it present on every cell or some of the cells? What exposure of the drug do you need to get an effect at that target? Did the drug or the treatment reach the target, and was it at effective concentrations? Did the drug have an effect on the target? So just because the target's there and the drug is supposedly inhibits it, does it actually affect it? And if it did so, did it interfere with tumor growth? Then we also need to know if the patient is benefiting. So now in the past few years, we've been incorporating this targeted drug development paradigm where preclinically we want to identify the targets and see what effect inhibition has on these targets. There's these phase 0 studies which are being done in small numbers of adults. These are called microdosing studies where you give very, very small doses of the drug, first time in humans, to see what the pharmacokinetics are and if you can come up with a marker to see if the target, inhibiting the target, is actually having an effect. Then it moves on to the safety, where we're actually continuing to test this pharmacodynamic marker and see if there's any biologic effect on the patient. And then phase 2, where you look to see if there's activity. Again, an additional step before it goes back to reach the children. So we have additional challenges in neuro-oncology than other oncologists have. In pediatrics, we also have this tumor heterogeneity that I talked about initially, where we only have hundreds of children diagnosed in the United States each year. And we have some tumors where we don't have any tissue. We don't know what the target is. So just for an example, for low-grade gliomas have historically been grouped together in studies in phase 1 studies in the past, or phase 2 studies even. These include grade 1 tumors, which are polycytic astrocytomas, the grade 2 tumors, which can be a little bit invasive, and optic pathway gliomas that are not biopsied. So these are all grouped together, and we expect the same outcome in phase 2 studies. You know, that's a big question mark. We should not expect the same outcome because we now know that biologically these are very different. Recently, there's been some information on juvenile polycytic astrocytomas, so that even these are heterogeneous. Even these with the same diagnosis act different biologically. About 75% have this gain at chromosome 7. This is just a chromosomal abnormality, and it's been identified with this BRAF, which is a target for which new agents are developed, and one was just FDA approved for treatment in melanoma. But this target is only present in about 7% of patients over 40 years of age. And there's 2 different types of these mutations with the BRAF. You can either have a fusion protein or you can have a point mutation. But again, the point mutation differs from this fusion protein, and not all patients have it. So again, heterogeneity is an issue. Even for pontine gliomas, a tumor that we don't have tissue on from biopsy is heterogeneous. We have done some studies on paraffin-embedded blocks, which are stored from autopsies of patients with pontine gliomas, and these have only been done recently. We know that if you look at the tissues under the microscope, some of them can be grade 2, and some of them can be grade 4. We've done comparative genomic hybridization, where we looked at are there abnormal chromosomes in these tissues. And this is what we call a frequency plot, where we looked at our entire group of subjects. We had 13 patients with pontine glioma who underwent this analysis. The chromosome number is across the top, so everybody has 22 pairs of chromosome, an X and a Y. Green is gain of an area of chromosome, and red is loss. And you can see there are some areas like 1Q where a number of patients had gain of that area. There are some areas like 10Q where there was loss in a number of patients. Every patient had at least one abnormality. No two patients had the same group of abnormalities.
Wouldn't that be a good argument to biopsy the tumor before?
Yeah, so we just had a consensus meeting for punting glioma to discuss this and some other information that's been coming out about punting gliomas. So not only do we have differences between patients, we have differences within a single patient. So these tissues were taken from the same tumor, the same punting glioma in a patient. There was one area that was low grade. There was a sharp demarcation in another area that was high grade. So we did this chromosomal analysis on both of them. You can see that the low-grade area had this abnormality on chromosome 3 and an abnormality on chromosome 9, and these were also present on the high-grade area, but along with some additional abnormalities as well. So if you have something that is going to inhibit this target, it wouldn't affect this part of the tumor. You wouldn't expect it to. So we know in general adult tumors differ from pediatric brain tumors in a number of ways. Pediatric tumors are frequently located infratentorially, which means the lower part of the brain, including the cerebellum and the brainstem, whereas the vast majority of adult tumors are supratentorial, or the cortex. We know that there are a number of different diagnoses that you can get in pediatrics. In fact, the most common malignant brain tumor in pediatrics is medulloblastoma. If you group all the gliomas together, that would be the most common. In adults, almost all malignant tumors are high-grade gliomas. The low-grade gliomas are much more common in pediatrics than high-grade gliomas, and the reverse is true in adults. In the pathogenesis, there are some adult high-grade gliomas that develop from low-grade gliomas, but that doesn't really happen in the pediatric patients. Now we're looking at genomics. Over the past several years, there's been a lot of information that's coming out. We know that the most common genetic abnormality in adult high-grade gliomas is amplification of EGFR. Now in pediatrics, we may see overexpression, but you don't see amplification that often. There's a different PDGF receptor alpha is most frequent in pediatric patients. These studies were all done on a very small number of patients. I'm talking in the teens and 20s for pontine gliomas. And so it's hard to make huge conclusions from these, but it looks that for a number of genomic aberrations, there are differences between adult and pediatric tumors. Now, if you have a target, you can have more than one target. You're not meant to be able to read this. These are the pathways that have been identified within a cell that are common in high-grade gliomas. Okay, there are a number of pathways that can be involved. These blue boxes are drugs that have been developed to inhibit that specific pathway. But the tumor cells are not static. They don't just sit there and take it and die. They try to find ways around it. So if you start inhibiting this pathway, they will try to use this pathway. Okay? So what we've tried to do now is target more than one pathway at the same time. Now we're faced with testing the safety of more than one drug at the same time in our patients, and we don't quite know how to do that. So there are some challenges. So we have the small heterogeneous populations in pediatrics. They have different tumor types. The patients are different sizes. You have a small baby all the way up to 18 adult-sized patients. Adults are usually first for drug development. We're right now trying to figure out how do we safely dose more than one agent at a time, and how do you determine a response in a patient that you don't expect to the tumor you don't expect to shrink. So our approach at the NCI right now is we want to continue to identify targets, okay? Try to put this story together more. We're only just at the infancy of doing this for pediatric tumors. We're looking at alternate delivery approaches, including convection-enhanced delivery, which is in the clinic now. Preclinically, we're looking at intranasal drug delivery, which actually is being used for Alzheimer's disease. Drugs get into the central nervous system. There's no blood-brain barrier there. We want to optimize dosing and do rational drug development. So figure out preclinically what is the dose you need to get adequate doses at the tumor site. How much of the drug crosses the blood-brain barrier? Right now we're doing studies in animals, monkeys to be specific, looking to see how much of the drug crosses into the cerebrospinal fluid, because these animals mimic what happens in pediatric patients, and so we save this from having to be done in children. We are developing some animal models both for pharmacokinetics and also for tumors. And we're looking at non-invasive means to identify responses. So this is a picture of the National Cancer Institute, the National Institutes of Health in Bethesda. If you don't know, we have a hospital. Basically, we do a lot of clinical trials here. If you've been there more than 5 or 6 years ago, this is what you saw. This is the old building, Building 10, and this was the clinical center. This is our new hospital and new laboratories, and it's beautiful. We have an entire pediatric wing right here. Children who come to be entered on a study can stay at the Children's Inn. We try to keep our patients outpatient as much as we can. Children's Inn is right here. I'll show you another image, but it's walking distance basically from the hospital. So everybody who's treated at the National Cancer Institute is treated on a study. You have to be eligible for the study. If you enroll, then we pay for travel back and forth. There's no medical related expenses at the National Cancer Institute. Imaging, drugs, everything is free of charge. We try to work with the home doctors, get the kids home as much as we can in between cycles of therapy. And we just bring them back usually monthly or so. So right now we have this multiparametric imaging study. We have a lab of diagnostic radiology research, which are basically a lot of MRI scanners that allow us to do research. So I'm sure most of you are familiar with trying to schedule a regular MRI scan and you get assigned like 10 o'clock at night or something like that. It's very hard to get time on a clinical scanner. But we have time assigned to us on these research scanners where we can do our investigational studies. We're looking at the effects of radiation. We know radiation affects the tumor cells, but we don't quite know how. We don't know how it affects the normal tissue. We don't know how it affects the blood vessels, and that's one of the things that we're studying in patients who are newly diagnosed and require radiation. So patients receive standard radiation with us, but we do a lot of fancy studies, and we follow them for up to 5 years with endocrinology, neuropsychological testing, and the ophthalmology, audiology, and other things for up to 5 years. We have some studies that are only being done within our institution. I collaborate with Brigitte Wiedemann, who runs our Pharmacology and Experimental Therapeutics section. So there are some studies that are being done for children with solid tumors, and that may or may not include brain tumors. There are some studies that are being done just in my section, which are specific for children with brain tumors. We collaborate with other institutes. This is the Neurological Diseases and Stroke Institute, where they're doing the convection-enhanced delivery, so our neurosurgeons are very good. And we also participate in some multi-institutional studies, including the Pediatric Brain Tumor Consortium and the Children's Oncology Group. Now, all of this is overwhelming. How will you ever get a drug next month for my child who currently has a brain tumor? And this is kind of scary, but there is overall some relatively good news. There are many new drugs that are being developed. Many are specific for a target rather than a population. So rather than trying to develop a drug for 200 children a year who have pontine glioma, instead, if you're looking at a population who has PDGF receptor alpha and a drug is being developed for that, that's something that may also be seen in melanoma, lung cancer, and other diseases, and so the drug may be available for children with brain tumors. We know a lot more about the biology of the tumors than we ever did. In fact, in the past 2 years, we've learned that pontine gliomas differ from adult high-grade gliomas. One of the reasons the FDA told us that we couldn't biopsy patients were that we can use the glioblastoma targets that are found in the adults and apply that to the kids, and we know that doesn't work. We also know that pontine gliomas are different from pediatric supratentorial high-grade gliomas. So again, you can't apply what happens to children with supratentorial high-grade gliomas with those with pontine gliomas. And we've defined that the gliomas of all grades are very heterogeneous and have a number of genomic aberrations. And so these challenges are being addressed. How do you incorporate these new drugs into clinical trials? How do you test the safety of these? And there was a meeting just this past month which they discussed a number of these, and the transcripts are actually at this website, which I think will be posted. So this is my group. We're a small group, and this is just the pediatric neuro-oncology section, but again, we collaborate with the Pharmacology and Experimental Therapeutics, who are in our branch. Our offices are right beside each other. We collaborate a lot with the radiologists and with the surgical neurology branch. This is something that the more collaborations that we have, the better. And in fact, we're at the point where we're establishing international collaborations, particularly for diffuse intrinsic pontine gliomas. I'll just leave this up here. This is a picture of the Children's Inn. kids and families love it here. So you have access to a kitchen, which is sometimes stocked, sometimes not, depending on who was there the night before. Basically, the children and their families can stay there. There's playrooms, there are business rooms, there are exercise rooms. They have all kinds of activities that are set up for the children. And a lot of our patients actually schedule their visits around the holidays or around vacations because it's a lot more fun there. And that's it. So I'll stop there and take questions. I hope that was helpful.
I actually have a bunch of questions.
Sure.
I'll try to ease them out slowly. So about 6 weeks ago, my daughter was diagnosed with the IPG. And my wife actually had called you, and she said you were very nice. Anyone who tolerates my wife for more than 2 minutes has to be incredible. So...
that was on video, right? You got that.
Thank you. So her illness progressed very rapidly, so we had no choice but to do radiation quickly. So we're under the care of Dr. Allen at NYU, and she's responding very nicely to the radiation. So we're looking at she only has a few sessions left, but she has pretty much full recovery, just some minor issues with her dad. So we're looking at for next steps. So I kind of grouped them into 2 categories: vaccine and delivering some agent via CED or some other process. So each of them present their own problems because of their issue and some other issues. So the vaccines that we're aware of, there was something being done by Gardner at NYU and University of Pittsburgh or Chicago. She doesn't qualify that because of some
HLA-A2.
Exactly. So that's out. Then there's something being done at Minnesota and something being done at Stanford by Fisher and Hodge. But she's not 3. There's a strict requirement on that because it's phase 1. So now we found Dr. Swadane at Cornell Weill, and he's doing some work with the CED. However, because of her age, she's 2, they can't quite, the surgery's a little tricky because they have to introduce some other pinning mechanism on the halo. So we're stuck in a really bad place. What I would like to do is, it seems very reasonable, to do a biopsy, figure out what's cooking in there, kind of target a drug, infuse it either by CED or some other mechanism, keep her alive for 3, go to Pittsburgh, get a vaccine, and try our best. Now that's the only cards that I know how to play. And if you see anything different.
So a couple of things. So again, go back to my risk versus benefit at this point. So our CED trial is only open right now for children who have recurrent or progressive punting glioma. And that's because the risks are still undefined. So even though our 3-year-old patient was back to baseline within 2 or 3 days, our 16-year-old was ready to go home within 24 hours. We had another patient who got worse from her baseline. And she never got back to baseline even though she improved. Okay, so in our hands, 2 out of 3 patients were able to tolerate the infusion well. But we still don't know what that is in other people's hands or if you do that for a large number of patients. Now, biopsy in itself, I think, is a safe procedure. The French have been doing it since 2006 or 7 on all of their punting glioma patients and have presented their data showing that it's very safe as a brain biopsy somewhere else, in their hands. Okay, so neurosurgeons have not been trained to do brainstem biopsies because it's not the standard of care. So it has to be in certain people's hands. If you biopsy a tumor, you may get an area that's not representative of the entire thing. So you may have some targets in that piece that are not present on the others. And so you're exposing, right, so you're exposing her to an investigational agent that may not be targeting all of the cells. And there are some side effects with all investigational agents. And so I know families want to do something. They can't stand the idea of not doing anything. And so we had a study using Pegintron, pegylated interferon, which is FDA approved for hepatitis, treatment of hepatitis. Basically, it was about 10 years ago they found out if you gave low-dose continuous exposure to the interferons, there's an anti-tumor effect in the laboratory. So we were able to take this and give it to children with pontine gliomas after radiation, before they progressed, because it was already FDA approved. There's lots of safety data, and we were using 1/10 of the dose that the FDA had approved for other patients with hepatitis. Now, did it work? So we have one patient what we wanted to do on this study was to see if the 2-year survival was better than our historical control. Our historical control, though, basically included all brainstem gliomas, not just diffuse intrinsic pontine gliomas. And that was the limitations that we had at the time that we wrote the study. So we did not show that there was improved 2-year survival compared to them. But if you take more recent diffuse intrinsic pontine glioma studies that are specific for DIPG patients that were similar to what we went on, the progression, the tumor probably came back a little bit longer than it would have otherwise, 8 months versus 5 months, okay? We have one patient who's out 6 years, but her tumor recently came back. We have one patient who's out 3 years, but her tumor is still there. So is this evidence that the interferon is active? I don't know, but it's well tolerated. We know it didn't affect quality of life. We need to go.
We really need to go. But
Sorry.
What we'll do is, if you're willing, to let them ask questions out in the lobby.
Sure.
Is that okay? Thank you very much.
Sure.
Thank you so much.